Coming to medical oncology basics. So the tobacco use and the cancer patient is the chapter number 2. What I am trying to do is decoding the data. What are the possible questions and what is the main crux of the chapter that we are going to discuss so that we can write in the exam. Coming to the chapter 2 is tobacco use in the cancer patient. So we are going to deal with tobacco and cancer. This is the chapter 2, and at the end we can make some useful note. So some background information has been given, like 100 million died tobacco related event. In the tobacco related event, so tobacco related deaths are 100 million in 20th century. Now we are in 21st century and 1 billion death is expected in 21st century. So 50% of people who are using tobacco, they will die related to tobacco. So the data is actually dangerously bad, that 50% of the people which currently smoker or using tobacco in any form is likely to die with the disease related to tobacco. A disease not essentially cancer, but all spectrum of the tobacco related disease. So it's not better than that today to leave the tobacco if you are using. Now there is some notion that tobacco industry is giving money to the government and government can't shut it down. So the scientists are behind that also. So US dollar 1 trillion worldwide. This is worldwide. 1 trillion is the estimate of economic burden due to tobacco sale. So 1 trillion market is there, but how much tobacco products, tobacco barons are using for cessation? Tobacco company using less than 1% revenue on healthcare activity or advertisement for not using tobacco. So the tobacco company is not actually fulfilling their thing, and 1 trillion worldwide the market size is there for the tobacco, and it's an economic burden. So actually the company is a win-win situation, is in win-win situation, and we are not. Now there are efforts to make cigarettes safer. So this is another topic. So if we are looking, data says that what is safer cigarettes? Safer cigarettes, the company often try to make the cigarette safer. What? They use it filtered. So this is the cigarette. Look the structure. Here is tobacco. You burn it from here, and there is a unwise man on this end. Okay, so this is simple tobacco. Now the company start putting filters or cotton pads or something which filters the smoke and claiming that the particle will be filtered. So carcinogenesis will reduce. But is it the fact? So one way is to use the filtered cigarette, but it has been found that this is not useful. Why? So deeper penetration, deeper breath is there. For filtered smoke, somebody is taking deeper breath, and the penetration of thin smoke is dangerously till the level of alveoli. Okay, false safety assurance. So people start believing that the tobacco is, this filtered cigarette is not so bad. So it encourages them to use it. So these two things is actually, and there is no data saying that the filtered cigarette will prevent the carcinogenesis or it is less carcinogenic. That is one way of doing it. So it's a marketing premise. The second thing which is likely to be asked to us is electronic nicotine delivery system. So This is something which is more likely to be as ants. What is ants? Let us see. In movies, you can see there is a long pipe, smoke, and they started in fashion like it is smokeless tobacco. Not a smokeless, it is tobacco-less smoke, tobacco-less cigarette. So it has a shape of cigarette, a bit long or something. It has a heating element, and there is some material of choice you can put, plus minus flavor. So what happens that you can put nicotine. So there's two different things. Nicotine is a salt. Tobacco has nicotine, but nicotine per se is not carcinogenic. Though some study says that it can, but nicotine is a kick to the brain. So it releases dopamine-like sensation in the brain, so people become addicted. Nobody want to smoke tobacco if we remove nicotine from the tobacco product. So the scientists put nicotine here, some liquid form of nicotine, hitting element, you on the ends, and it will hit the nicotine and you inhale it. Okay, so it gives a pleasure of this cigarette smoking without the problem of this carcinogens entering in the body. Now, seems good, but there is a problem. So this and flavors you can put any rose, any flavor, whatever you want. So problem with this is a short note. So electronic nicotine device, we are going to make a diagram. We are making to going to inform how it is working, the vaporization of liquid and the inhalation of that, but it causes something evaluate. So side effects or problem with nicotine device delivery system is evaluate is e-cigarette vapor associated lung injury. E-cigarette vapor associated lung injury. So you are inhaling a hot vapor of nicotine to the lung with every breath, and it is problematic. It can just causes lung injury because of the thermal thing. Now, coming to apart from evaluating what it can do, so there is a drawback, like it gives false or at least security sense that smoking is okay. So if a kid start doing using this ends, more likely one day or other he is cool with the smoking and he will try the cigarette. Okay, just to see what is the difference between ends and cigarette. So behavior ratio. So it is likely that a person using ends will end up using original cigarette just to compare. So it discourages quitting. Okay, and the more younger people will get addicted, more youngers will come for it, because falsely we are thinking then it's safe. Now it's safe, no doubt, because there are regulations which says that it is useful, and we'll see the regulation. So for these reasons, FDA says ends is not a method of quitting the tobacco, but this UK Royal College of Physicians endorse ends for quitting smoking. In general public, so there is mixed thing, and for these reason it is not recommended. What is in India? So India is with the FDA in this thing. India passed a rule, PECA 2019, Prevention of Electronic Cigarette Act. So PECA puts the electronic cigarette in at the par with the conventional cigarette, and it's used in public place, in its sell to the minor, everything. The Indian government says no to ends. So that's about ends, and they are likely to ask, and is one of the important question ends. So now the third part comes, like classification of smoking status. smokers or smoking status. So earlier it was like never a smoker, see less than 100 smoke cigarette in lifetime and not smoking now, not smoking nowadays. That is, he has quit. So if somebody has started and he has reached 90, he is also a legitimate target to enroll or encourage for quitting it. So who is not a current smoker, left the smoking? What is a current smoker? We'll see. And never a smoker whose score is less than 100. So sometime for a fun he has taken it, but now he's not smoking. The other group is ever a smoker whose count has crossed 100 cigarettes. Now ever a smoker, we have former smoker. Former means the count has crossed cigarette 100, but he has quit more than 1 year. Recent smoker or recent quitter. So 1 week to 1 year is the time period he has left the smoking. So at least not for a week he has taken any cigarette, but it is less than a year, otherwise it will be a former smoker. And the current smoker who is obviously taking smoke regularly and he has taken in the week. So this is correct. Now the thing is, these are stigmatic terms. So the book says that we can change the terminology also to a lower stigmatic term, like person who is currently smoking, then previously smoked and never smoked. That is more human way to say a person who is currently smoking, than a smoker. That's one way to destigmatize or more respectful. Or the former smoker, that is the category more than 1 year. Then recent former smoker, 1 week to 1 year. Then long term abstinent smoker. So he has left more than 5 year or more than 15 year. So these are the terms now replaced, but the basic definition is this, and we must know this. So thereafter the book says that who is putting the effort for quit smoking or for the quit smoking of general population. So the data is actually not good. It says that in head and neck cancer, 33% patient reports smoking and 53% of them continue during treatment. So they are not quitting. Head and neck cancer, when we are more worried or it's a visible thing for them that smoking has caused it, still they are not quitting it. 44% current smokers, general population, not a cancer patient, they never get advice of quit smoking. So they never received any advice. No advice of quitting reached them. Okay. And 84% of them has visited doctor. So even doctor is not taking it seriously, and this is the missed opportunity. And when they do the survey of oncologist, so survey of oncologist, 90% take history of smoking. So at least they are aware. 80% advise for quitting, and they say that okay, you should quit. 30 to 40% only discuss how to quit. So just saying that okay, you should leave the smoking, knowing that nicotine has dopaminergic effect, and the person is not going to just stop it. So providing assistance or information in detail is only 30 to 40%. So even oncologists are not serious about it. So earlier it was like that person has to say, then okay, opt in that I want to stop the smoking, or you try to convince that okay, you opt for cessation program. So your center or many of the center or as per the government norm, every center tertiary care should have a smoking cessation center attached with it. So earlier it was like the person has to reach them, their OPD, make a registration, okay, meet the doctor, ask for what to do. It was a utterly failure because the addiction is not addiction if you are easily going to give it. Now the approach is opt out. This in another short note or the question asks for two numbers. So only thing that we should know what it says. It says that all smokers, that is current or just short-term former smoker. So you see, we are targeting recent smoker, current smoker, former just to maintenance. There is no need of cessation center to go. The doctor has to assure that he remains the former or current smoker or recent smoker who is likely to fall again to the smoking trap. They are enrolled for tobacco cessation activity without asking. The government says that whenever you get opportunity, just push them to the tobacco cessation activity. Okay, so you are a smoker. Now see, you have to leave the smoker, how long you are taking. So there are approaches to do that. We are going to discuss. Opt out is if he is not willing, if he is not ready to quit, he can opt out. So by default, he is a legitimate target for our tobacco cessation campaign and he has to opt out if he wishes to go away from that. So this actually improved the outcome because now whenever we are finding something, we are automatically helping them to okay, universal screening whenever we are doing the cancer screening, do the universal screening, pick up the person, refer them or advise them or assist them. And if they are not happy about it, let him or her opt out of the program. So that's the new approach. And from where we can find the cancer patients or the smokers. Okay, so smokers are screening, healthcare screening. We must ask OPD visits. We must ask volunteer declaration that okay, help, that is also okay. And then for any reason, if he is going there, survey in society community services survey, you can ask and then automatically let him opt out if he is not willing. So now the third thing is which is important apart from definition and opt out, and the third or fourth thing is carcinogenesis. A frequently asked question, carcinogenesis of tobacco. So to simplify it, see, we have tobacco smoke and we have lot of things in that smoke. So some around more than 100 or near 100 carcinogens are there. Some book says 164 carcinogens has been identified. So smoke is a conglomerate of all type of carcinogens. So some important are heterophilic compound, N-nitrosamine, aromatic amine, heterocyclic aromatic amine. I deliberately put all amine on one side. So some of them we should remember. Aldehyde, so volatile hydrocarbon, then phenolic compound, nitrohydrocarbon, heavy metals, and inorganic compound, polycyclic aromatic hydrocarbon. So in metal we have nickel, arsenic, chromium. So smoke is a conglomerate of all these things. More than that, around 164 known. But what we should know, the sum of the word like amines, nitroamine, aromatic amine, heterocyclic aromatic amine. These amines are dangerous. Then polycyclic aromatic compounds, aromatic hydrochloride, aromatic hydrocarbons, then heavy metals. Then so there is nitrogen, this is hydrocarbons, and this is cyclic, and there is amines related to nitrogen. So these all conglomerate, aldehyde, volatile hydrocarbon, everything is there. So why we are worried? So each one of them are carcinogen, but some are very known carcinogen. So some words like polycyclic aromatic hydrocarbon, that is PAH. If you have been asked about the component which is causing cancer in certain type, you can put PAH, you can put NNK, you can put the benzene for leukemia, blood cancers. So let's have something like lung cancer, the PAH, the NNK, that aldehydes, that benzene, metals, everything. Larynx, PAH, nasopharynx, the nasal cavity, NNK, NNN, and nitroso, and then K and N. These things are complex names are there for hydrocarbon. Nitrosamine, esophagus, NNN, nitrosourea, liver, NNK, nitrosourea, cervix, PAH, NNK, bladder, 4-amino biphenol or biphenyl compound. So bladder is phenolic group, leukemia is benzene group. So ultimately, if you know some of the name, and you can devise everything else. Now how they are working. So actually, whatever way we know that oncogenesis happen, we have to put this carcinogen into that. So there are a few diagram given in DeVita. I'm discussing DeVita chapter 2. So not going much haywire here and there. So start initiation of smoking. So these particles, that is products of smoking, is causing carcinogenesis. There is receptor binding, then protein kinase A, B activation. Now the other is uptake of carcinogen by cells. What cell will do? Excrete or repair. So if not, then DNA adapt, either repair, apoptosis. If not, then this is the persistent DNA damage. Then this is mutation or oncogenesis. Again, the protein kinase AB help in oncogenesis. So then this is gene promoter region, hypermethylation. So tumor suppressor gene, decrease oncogenesis. So by and large, what happened? There are 2-3 pathway only. One is that DNA has to get damaged. Okay, so these form adapt and ultimately leading to the damage. Then epigenetics means not the working gene but the controlling gene, and tumor suppressor gene is depressed. So tumor oncogene is DNA adapt, tumor suppressor is also depressed, and then through the receptor, that is the microenvironment is also altered. So this all conglomerate is causing lot of receptor activation. If we look at the receptor activation level, so this compound is just activating STAT3, and then this is anti-apoptotic. So JAK-STAT pathway is there, JAK is missing, STAT3 is activated, then KRAS, so RAS pathway, MEK, ERK, and then oncogenesis. Then it can cause, obviously, KRAS is linked with NFK beta, and NFK beta pathway, again, anti-apoptotic. So then it's working on PIK3A, and then AKT, mTOR, this pathway, and then it is also working through P53, suppressing the P53. So all pathways are mixed with, so with RAS-RAF pathway, with PIK3, mTOR pathway, with TP53 pathway, so and JAK-STAT pathway, everything is activated, leading to the carcinogenesis. So if we know for the carcinogenesis, I will suggest this diagram, some pathway, essentially this one, and whatever you can remember. This is the carcinogenesis. See, rest, it's a 2 marks question, and 2.5 page or 3 page given for that. So make diagram, write about it, and that's it about the question. Now the fifth important thing is smoking cessation, ways of smoking cessation, or smoking cessation guidance, and what we can do. So short note on smoking cessation techniques. So there are, Devita says that there are models for it. Okay, the first is you ask. So every person you are encountering in your OPD, ask, define them, whether they are former smoker, they are current smoker, they are recent quitter. So the ask is the most important thing. So they have question that have you asked, have you taken at least 100 or more cigarette and currently also taking it? If you say no, I have just tested once, left it, or not a current smoker, or but never tested more than 100. So just leave. There is no need. If the answer is yes, you ask the second question. How frequently you are smoking? Every day. Every day is a current smoker. Someday is a current smoker. Not at all. That is might be a former. Okay. Then you ask other form of tobacco you are taking. Other form. Okay. So we define like ever smoker, never smoker, former smoker, current smoker. Not only cigarette, the other form of tobacco you are taking. So then we define. With this, we define the target population. Okay. All current smoker should seek some should be rolled in. So now the approach is opt out. So everybody should rolled in for the tobacco cessation thing. Now after that we have model of how we are going to help them. So we did ask, we defined, and then we start advising. Okay, so give the advice. Advise them to stop this tobacco, taking tobacco. So will they stop? Not sure. Advice has many part. Okay, simple advice. Then you advise with a biofeed mechanism or send for the counselor. Okay, advice thereafter the model divide into 3 parts. Either you refer to a counselor, what we are discussing here. This model is AAR or AAC, referral or counselor access. Or what you do, you start with a 5A model. Then after giving advice, ask advice, then what you are going to do, assess how much he is getting into your advices, assess for the his willingness, his compliance. So repeat visit is required, then assist. If he requires some assistance, it may be psychotherapy, pharmacotherapy, counselor access. So whatever he is asking or whatever the need, you arrange. So this is 5A. Ask, advise, assess for the advice, assist him, and arrange a counselor access or the intervention access. So these two models are working. So tobacco cessation, this is one of the important question. Okay, so the tobacco cessation has 5A or 3A model, and ask is when all the definition comes, like ever smoker, never smoker. Never smoker, there is no need to enroll. Ever smoker, then former smoker, current smoker. So if he has quit more than 1 year, there is no need for this all 5A or AR and AC. And if he is current smoker or if he is likely to fall back, then we have to follow this. So then opt out approach is there. So that two things suffice for the tobacco cessation activities. Now the sixth part of this is pharmacotherapy. Less likely to be asked in isolation, but yes, as a part of question tobacco cessation one can ask. They discuss pharmacotherapy. So what is the target of pharmacotherapy? See, we have to understand that the nicotine is the main culprit. So nicotine goes to brain, stimulate dopamine like sensation or dopamine that gives a pleasure. So somebody is smoking and he is feeling the kick because of the nicotine which releases the dopamine. Now there are two type of thing. The source of nicotine, change the source. So what you are doing, you are segregating smoke and nicotine. So we are going to provide a nicotine in a non-smoker way. That's where the ANDS was endorsed by UK College of Physicians, not by India, not by FDA. So we are not using it. So segregating means you give nicotine and stop smoking. Now how we can give nicotine? Patches are there, all forms are there. Patches like analgesic patches are there, so stickers are there for nicotine, then gums to chew, then lozenges, nasal spray, inhaler. So all form of nicotine are there. So one can give the nicotine, and nicotine usually saturate the receptor. Initially that kick-in is there, but receptor gets saturated and gradually you can withdraw the nicotine. By the time the smoking will go. So depending on how heavy smoker he was, we have to start nicotine accordingly. Like one example is patch. It comes in 7, 14, 21 mg for 16 to 24 hour. Strength is there. If somebody is taking more than 10 cigarette per day, that is a heavy smoker, start with 21 mg patch. You have to apply every day or in 16 hours. Give it for 6 weeks. Then step down to 14 mg, 2 weeks, so total 8 weeks. Then 7 mg, 2 weeks, 10 weeks. If he is taking less than 10 cigarette per day, likely that 21 is not required. 14 mg, give 8 weeks, and 7 mg, 2 weeks. So this 8 week and this 8 week, depending on cigarette, how heavy smoker he was. Gums, it come in 2 to 4 mg. Maximum one can take 24 mg per day. So 24 gums per day. So one have to just chew the gum like nicotine, Nicotex. These are the gums commercially available here. So first smoke is less than 30 minutes, more than 30 minutes after waking up. That is okay. He gets up from the bed and he's okay 30 minutes. So that means he is not so heavy smoker. 2 mg every 1 to 2 hours. If he requires smoking less than 30 minutes out of bed, so first thing you want to do smoking, then it is 4 mg every 1 to 2 hours. Then you taper. Okay, so obviously the program is for weeks. Then again lozenges, nasal spray, inhalation, all form of there. Now that is one way to give dopamine to the brain by giving nicotine and detaching it from the smoke. The other effective way is to give the dopaminergic agonist directly, bupropion and varenicline. Varenicline is more potent. So these two pharmacotherapy apart from nicotine is approved. Bupropion, it increases dopamine. and block nicotine receptor. So it prevents reward feeling. So on dopamine, on bupropion, the if the patient is smoking or it left the feel of reward, like okay, I have smoked, now the dopamine will be released because dopamine is blocked. So it is actually detaching the dopamine stimulation. So even if he's smoking, the dopamine receptor is blocked. He's saying, oh, this is useless. Varenicline is again blunting the reward by blocking dopamine, by sustained dopamine level. So not only blocking dopamine, sustained level. That's how the kick is there, but not due to nicotine. So whenever he's trying to take smoking, there's no reward. Okay, so nicotine is useless now. So for them, varenicline and buprenorphine is a potent. Varenicline 0.5 to 1 mg, buprenorphine 150 mg. The dose like one tablet OD for 3 days, then BD, when BD, then you have to titrate. So there is a sequence of that. There are second line also. Somebody is failing. Clonidine and nortriptyline. Okay, so there is a theoretical risk. Theoretical that if we give nicotine patches or gums to chew every 1 to 2 hours, is it carcinogenic? So although Canadian study found that there is no real world carcinogenic effect. Canadian study, no real world carcinogenesis. However, theoretical risk is there. Now, how apart from causing cancer, smoking is dangerous in many forms. So the final part of the chapter says, I think this is final, yes. Final part of chapter says that there are clinical effect of smoking in the oncology. So we will just quickly see. Smoking is carcinogenic that we have seen. Okay, till now for the many 164 compound and causing this, it increases treatment failure rate. So increase recurrence. It increase cost of cancer care. Also, side effect increase and comorbidities due to smoking. So somebody can develop COPD, cardiac issues, increase second cancer chance. This is interesting. So if Hodgkin lymphoma is continuous smoking, the chance is 4 to 7% more in a smoker for the relapse or for the second cancer. If ER positive CA breast on radiation, the risk of cancer to the other breast is 9 times more if the person is smoking. So the chances increase, and increase interaction with novel therapy. Now this is something interesting. So the novel therapy says something else. Smoking increases PD-L1 level. So immunotherapy should work more in smokers, but it's not like smoking is beneficial if we are planning immunotherapy, but it is like PD-L1 expression is more. Similarly, if we are giving PARP inhibitor, it is more active in a smoker. So these two things exceptional, where the smoker can have a laugh and saying that okay, this is going to work more. Otherwise, a recurrence, side effect, cost of care, thereafter poor healing of surgery and radiation wound, lot of thing is there. Okay, and what happens when we quit smoking? Quit smoking, what happens? Outcome improves. So 45% median improved survival outcome. So there was a study that stage 1 to 3 CA lung, stage 1 3, that is non-metastatic, 321% who quit smoking, the mortality was decreased in comparison to the cohort where smoking continued. Similarly, in small cell lung cancer, then improve tolerance improve, quality of life improve. So CLM studies are there. Who is current smoker? Increase pulmonary event risk 80% and mortality 3.5-fold. 2-week cessation, so pulmonary risk decrease. 1 month cessation, even mortality starts showing decreasing trend. So obviously it's not going to be as per non-smoker. What we are discussing here, during the treatment, if somebody is continuing smoking, the mortality as well as every problem is more. So even a quit of 2 week, 1 week, 1 day is okay. At least pulmonary toxicity will decrease. So this is what the chapter says. Now there is something I have written on the top of chapter. I will just discuss that. So we must know some words. Rest is a story you have to make. Like there are programs, National Tobacco Control Program in India, 2003. Then there is a helpline, National Tobacco Quit Line Service, that is 1800112356, 24-hour service to help. Then there is mobile cessation, so mobile cessation support, and that is thereafter Quit Tobacco Be a Hero campaign. So these are the governments that what they are doing. Right now the tobacco quit line is active. You can ask for the mobile support also. This is one thing. Then what are the strategies? If somebody is asking, the Devita put a table which is nothing but what we have discussed. So encourage them to quit, okay, provide assistance, give education about harmful effect, recognize high risk population, and environmental factor. So suppose a child, adolescent is coming, smoker, and you want him to quit, and whole family is smoking. So then it's less possible like he will quit. So then psychology has to be changed. Then family, prevent relapse. So one is quitting, then after few months will again start. And then how we have to give motivation, we have to give behavioral strategy, relaxation, congratulation for the quitting, these all things, and feedback, sorry, callback. So just a call, repeated call, that how are you are still a quitter, that will help. So this is about the chapter number 2. So I think that's about the chapter number 2 in Devita, and one of the most important topic, that tobacco and smoking. I hope you like it.